Moderator is my colleague, faculty member in the MacLean Center, Dr. Justine Landy, who is an assistant professor in medicine, specialist in geriatrics and palliative care, and also co-director of the MacLean Center Clinical Ethics Consultation Service. Justine.
Good afternoon. For our first session, titled Resisting the Robot Surrogate, Dr. Kyle Karches, MD, PhD, is Associate Professor of Internal Medicine at St. Louis University. He received a BA in Philosophy from the University of Notre Dame and an MD from the University of Chicago, where he also completed residency in internal medicine and a fellowship in clinical ethics. He also holds a PhD in healthcare ethics from St. Louis University. At St. Louis University, he practices general medicine, chairs the ethics committee at SSM St. Louis University Hospital, and directs the ethics curriculum at St. Louis University School of Medicine.
Thanks, Justine. It's great to be back at the University of Chicago and the MacLean Center, both places that really mean a lot to me. So this talk's entitled Resisting the Robot Surrogate. And, okay, trying to click ahead here. Okay, so here's my, I don't have any disclosures. Here's my outline. So I'll start by describing the P4 proposal, the proposal for the robot AI-enabled surrogate, and then I'll outline some arguments against it. I'll argue that it's neither technically feasible nor ethically desirable. So I'll start with the P4 proposal. What is it? So it comes from this article, which was published earlier this year in the American Journal of Bioethics, in which this group of ethicists, largely from the Uehiro Center at Oxford, argued that an AI-enabled surrogate decision maker is both technically feasible and ethically desirable. And they start by outlining some problems with surrogate decision making with which I imagine many of us are familiar. Advanced directives are rarely available, and when they are, they're not always helpful. It's not always clear how they apply to the situation at hand. In studies of substituted judgment, it's barely more accurate than chance. In some of the best studies, about 60% accurate, so only a little bit better than a 50% coin flip. There are often multiple surrogates involved, and they may disagree about the patient's preferences. An example would be the Terry Schiavo case, in which her husband disagreed with her parents about what was to be done. And that surrogates experience high levels of stress. In surveys, they report levels of stress comparable to having their house burned down and losing all their possessions. This is extremely stressful on surrogates and something that many of us are very familiar with if we do clinical ethics. So the solution that they propose to all of this is the Personalized Patient Preference Predictor, or P4. The authors note that they previously proposed a P3, an AI that would use purely demographic data, age, gender, race and ethnicity, in order to predict the individual patient's preference. And they got a lot of pushback about this because they said it ignores the individual and how they may differ from the characteristics, from these kind of demographic characteristics. And so they say the P4, now that AI has advanced or will soon advance to the level that we can use machine learning fine-tuned to the individual, using not just demographic data, but other inputs such as EHR records of the patient's previous decisions, social media, emails, purchases, and they even propose that we should push out to cell phones a decision-making app in which patients are prompted to make decisions and input yes or no answers, and this will be used also as data to predict patients' future preferences. What arguments do they offer in favor of this? Well, they actually say that they believe that their P3 did pretty well in predicting patients' preferences, and so it stands to reason that the P4 would fare even better. LLMs can already predict survey answers, movie ratings, and other things that have been shown in studies to be able to predict this reasonably accurately, and so there's no technical hurdle to being able to make these medical decisions. That surrogates' claims to treatment decisions are not independent or exclusive, that surrogates don't have exclusive rights to make decisions. There's obviously the involvement of the medical team, and so they shouldn't be able to exclude the P4 from being involved in this process. And then they consider some counter-arguments that this goes against patient privacy, and patient autonomy, and they have responses to those. They say, well, we can put guardrails on it. We can require the consent of the patient or surrogate or use or use only publicly available information in order to inform the P4, that we can store the information locally instead of making it hackable online. We can make this an optional tool to help, not to replace surrogates, to inform surrogate decision-making, not to replace it, at least at the beginning. And in response to the idea that on a kind of a deeper level, an LLM can't appreciate the reasons that a patient might have made a particular choice, they say that surrogates often don't appreciate those reasons either, that they know that a patient might want something, they know that a patient might want something, but they don't always appreciate those reasons well, so there shouldn't be that obstacle to the P4 either. Well, against these arguments, I'll start out by pointing out that I actually am skeptical about the technical feasibility of this. Just on a basic level, if you've used ChatGPT or other AI-enabled chatbots, you know that they are currently prone to glitches that are called hallucinations, maybe better called confabulation. So here's a kind of humorous example. If you put into ChatGPT, what is the world record for crossing the English Channel entirely on foot? It will give you an answer that the world record for crossing it on foot is held by this person who actually crossed it by swimming, and it gives you all of this information. And of course, techno-optimists think that we'll overcome this hurdle eventually, but there are others who believe that we won't. And I don't have time to kind of get into the technical weeds there, but there are people who think that this might actually get worse over time due to something called the curse of recursion, which you can look up. But at a deeper level, a more philosophical level, I also think that there's a problem here in the way that an AI is dependent on linguistic inputs. It requires a prompt, and so therefore presumes a clear and stable meaning to that linguistic prompt. And I would argue that that's not really the way that we humans actually use and approach language. And here I'm going to draw from the philosophical tradition of phenomenology, particularly Gadamer and his discussion of hermeneutics. So hermeneutics is the art of interpretation, of the interpretation of text, which Gadamer believes is important to all human knowledge. And Gadamer argues that in human affairs, like ethics and politics, as opposed to the hard sciences, truth does not arise from the application of a replicable method, as in the sciences, but rather from this faculty of judgment. He calls it tact, or phronesis, practical wisdom, which Aristotle distinguished from episteme, which is the more kind of scientific knowledge. And this tact, or phronesis, practical wisdom, wisdom in the practical everyday affairs of human life, is formed by Bildung, life experience, and a life narrative. And an example of this with which many of us are familiar is clinical reasoning. The process of medical education, at least 7 years of post-baccalaureate training, only makes sense insofar as we understand the importance of experience in shaping this ability to make judgments about individual patients. And of course, that clinical reasoning is informed by scientific method, but also by other sources. When I encounter a patient, for example, if he or she uses an idiom in explaining his or her symptoms, I can understand that because of our shared cultural background, our shared Bildung, and reaching beyond these sort of scientific sources. In addition, although my judgment about that patient may be informed by science, the individual patient's needs may require me to go beyond, to push beyond the boundaries of what is known, and to even put at risk my settled understanding of something, to go beyond the guidelines in meeting this individual patient's needs. And it's also informed by my ethical commitment to the patient. It's the fact that this patient's outcome matters to me that may lead me to pursue truth in a kind of dogged way, to expand my differential diagnosis, to not be satisfied with what is already known. And I would argue that LLMs lack access to these metatextual sources of meaning. Nothing matters to them in the way that a patient matters to me, and they put nothing at risk in the way that I do. And I think that this will be fatal to its ability to technically replicate the way that humans make decisions. And I think that also makes this not ethically desirable either. An AI, an LLM, would rely on a kind of inductive reasoning, this method of probability maximization and utility maximization, seeing the satisfaction of preferences of the maximization of utility, in which the patient's identity and prior expressions of their preferences predict future choices in a linear way. But I would argue, and again, drawing on the tradition of phenomenology, this is not, in fact, how humans make decisions. Our decision-making is often more contextual and intuitive. Edmund Husserl, in describing this, forgive the jargon here, but says that when we face a decision, we first shape a protension, a hoped-for future, and that leads us to call forth retentions, these memories of past decisions, and to put a filter of relevance on them, to call forth certain aspects of those that we think are relevant to this particular decision at this particular time. And then this process is recursive. We reinterpret those memories in light of the current situation and the hope for future, often in a moment of insight. And it's that fact that allows It's not just a simple deduction. It's that fact that allows us to sometimes surprise even ourselves with the decisions that we might make in a particular situation. An example of this that's well known from the literature is called the disability paradox, that people who are disabled often rate their own quality of life much higher than other people who are judging the quality of life of disabled people from the outside, even those people before they become disabled. So an example is that if a person might have said previously, if I were dependent on a tracheostomy, for example, I would not want to live under those circumstances, but then they find themselves with a tracheostomy and say, actually my life does have value, and I think I do actually prefer to continue life. So humans weigh memories and experiences not just formally as just an expression of pure preferences, but existentially, emotionally, and spiritually. By contrast, the P4 has only what Bernard Stiegler calls a tertiary attention, just a record, a textual record of events, not the full retention, the actual experience of that memory, nor a kind of shared experience that a friend or a relative might have in my own going through that process, just a textual record of these events. And so it can only dictate a future that's already ready-made in the past. It doesn't have this ability to be flexible in response to this sort of new situation in which one finds oneself. I also think that this ignores the other goods that are available when we have family and friends as surrogates. I think we should take seriously the communitarian argument that my identity is not purely and simply my own, that it's constituted by my relations with others, especially close family and friends. If you were to ask me, who are you, and to tell my life story, I would have to tell that story in reference to the others, the people who are closest to me, to my parents, to my wife, to my children, to the fact that I grew up in a certain in a certain place with a certain cultural background, the fact that I'm an American. So I would inevitably make reference to these communitarian aspects, these community aspects of who I am. And so why do we need a robot construct of the individual? When we have a family meeting, when the people who are closest to that individual come together for a family meeting, the patient is in that sense in the room already. These people who love that patient and who that patient loves have a stake in that person's life. They shaped that person's identity. And the participation of the family then broadens the meaning of that decision beyond who has autonomous control. And what I mean by that it has reference to that last point that the P4 proponents made, that surrogate decision making is difficult. And in a sense, that's a bullet that I'm willing to bite. I agree that it is difficult, but it should be difficult. And I would say that love simply means, we could almost define love as a willingness to bear burdens for one another. And it's often, in addition to the community aspects of my life, my loved ones, the things that often have the greatest impact on my life narrative and explaining who I am are often those things that are hardest. Becoming a physician, becoming a parent, taking care of my parents as they age. These are difficult things, but they shape the meaning of my own life and my own narrative. I would say members of a family have a claim upon one another and should be the primary source for making decisions about patients. So consider a case, an example of what I'm talking about. So consider a patient who receives a diagnosis of a cancer recurrence with a poor prognosis. This event, this new situation, calls forth memories. She remembers her prior struggles with chemotherapy, the past choices that she's made, and she begins to interpret the present facts in light of these retentions. She starts to make judgments about what is relevant, not simply what is frequent or likely, as an AI or LLM would, to generate a kind of probability, but rather what is relevant from her past memories as she calls them forth. And she interprets those retentions in light of the present facts and what she hopes for in the future. And as she thinks about her prior experiences, she begins to move toward this idea that I'm going to forgo further treatment, following from previous experiences and choices. But then she remembers something. Her first granddaughter has an important religious ceremony scheduled in a few months. And now, all of a sudden, the past, the present, and the future look different. Death takes on a new moral significance. She seeks to delay it. Now, this decision is informed not just by a simple calling forth of these past expressed preferences, but also by the everyday experience of the love of her family and her own expressions of love for her family. Her love for her daughter, her son-in-law, her unborn granddaughter interrupt the straight line that she had been imagining, and a new possibility interrupts. And she reverses that protension unpredictably, because it draws upon not just previous expressed preferences, but the current situation in which she finds herself. Is AI capable of that kind of insight, of that kind of human judgment? I would say no. Surrogate decision-making involves human moral judgment. It involves these hermeneutical judgments of memory, of experience, of what we hope for. It involves risk and responsibility for one another. And so I would argue that surrogate decision-making, for those reasons, will always replicate better than AI, even if it can overcome relatively simple technical problems such as hallucinations. It will always better replicate the way that the human patient actually makes moral decisions. And these are my references, and I'm happy to take some questions.
Okay, so I've never used ChatGPT, so frame this question within that context, but I agree with everything you said, and then I wonder about the unrepresented patient, the folks who don't have love and known values and preferences informing their care, and I guess maybe in an ideal world, we'd have advanced directives for everyone to know what their values and preferences are, but still there would need to be some manipulation of those values and preferences to the situation. Like, do you see that as an opening or a reason to potentially train these tools?
Well, at least in my experience with unrepresented patients, it's a lot of times they not only, don't have other persons who can represent them, but they also, often wouldn't have the kind of data available to train an AI on what their preferences would be anyway. So, you would need to somehow have already had these unrepresented patients have had these kinds of inputs. And I guess I wonder if that were the case, if there were a sufficient record in order to generate a decision from a P4, would it really be the case that it would be that much better than, at least our practice at our institution is to get a multidisciplinary committee together of different stakeholders and to try our best to interpret the patient's previous preferences. Would it really be any better than a group of human beings who, again, have this commitment to this patient, have a shared cultural background, can maybe interpret a little bit better than an AI can what this patient's preferences are in these previous moments because we have access to these metatextual sources of meaning? Would it really be any better? I'm skeptical as to whether that's the case.
Thanks for your talk. I have a very oddball question for you. I apologize in advance for it, but here's my question. What if there's a God? And let me explain my question, because I know otherwise it would be perplexing. Let's say if there's a God that's understood the way that many religions do, some being that's all-powerful, all-knowing, and omnibenevolent. That being can't share burdens with you, and that being doesn't have anything at risk, and that being doesn't have a human experience, right? And yet we know that many patients would very gladly put their medical decision making in the hands of that being, right? Like patients routinely say things like, I'll just, whatever happens is what God decides. I'm praying for a miracle. So it seems like there is a lot of desire for decision making by a being that doesn't have human type experience. And then I wonder, is that not a counterexample to your claims that it applies differently they apply differently to AI than they do to God? I acknowledge that, but it still seems like it might be a counterexample to this idea that they're saying essentially human and making medical decisions for others.
Yeah, it's a fascinating question. I have to brush off my theology knowledge a little bit. So, I guess I would say, first of all, in some religious traditions, it at least is the case that God does possess human knowledge. Certainly in Christianity, that is a central tenet of the Christian religion, that God, insofar as God takes on humanity, has that kind of human knowledge, and so would have access to those sources of meaning as well, wouldn't be making it from a purely sort of separated standpoint. I'm not qualified to sort of say how that would cash out in other religious traditions. I'm most familiar with the Christian tradition, but I would say that at least that would be one response to that actually is not an accurate representation of at least Christian theology. But in another sense, I think that you could say, if that a God that has perfect knowledge, of past, future, is truly all-knowing, would somehow have access to those sources of meaning, whereas an AI, we can never create something that would have perfect access to that an AI will always have to have a method programmed in. This is going back to Gadamer's point that it'll involve an algorithm to train it, and so that truth for that AI will always be this kind of methodical application of an algorithm, and that just doesn't approach the way that humans or maybe God has knowledge. That it's different from the way that human beings. So from an existential standpoint, that I guess I'm saying that I would rather have a human being who shares my own frailties and my own vulnerabilities, and therefore has access to those sources of meaning, be present in making decisions. And insofar as God has that knowledge, maybe that, but I don't think an AI ever could, and I think that difference is important.
Speaking to this also, there is a problem in AI because of, it's called the consciousness, the big problem of consciousness. And maybe Nagel said what it is like to be a pet.
Right.
So the experience is different than the contextual analysis of the text. So still there would be an experience that AI messes to interpret the decisions for the people. So
Yeah,
there.
absolutely. I mean, I think that's what is it like to have a preference and to express a preference, and AI can know that, but it doesn't have any access to know how. It doesn't know what it's like to have a preference, to express a preference, to have responsibility for family members in a meaningful way, and I think that those are always present when we make a decision. It's never just a pure spitting out of text, yes or no. Always, human decision-making is always contextual. It always involves, emotion and memory in a complex way that can't be represented purely textually. So I completely agree.
Yeah, so it's Carmichael. He's one of the philosophers in philosophy of mind, and it is still a big problem, the problem of consciousness to AI. Thank you.
Hello. Thank you for your talk. My question is, if we're thinking about AI versus another human as being a surrogate decision maker, is it possible that you could be giving too much credit to the human that's competing with the AI? Because while AI may not be able to fully understand all your experiences as a human, like how many people can say that another human fully understands their experience as well? And could AI have the benefit of being a sort of blank slate without its own agenda, whereas another human may impose its own will onto your preferences?
Yeah. Yeah, thanks. So, I mean, I think in some ways I even think that we have to think about how we're asking the question of, of accuracy and things like this. So, for example, in these studies of accuracy of decision making, it's not exactly the same thing when we have sort of, we take a prospective patient, put them in a room and say, what would you want under these circumstances? And we take their surrogate and say, what would they want under these circumstances? That's not the same thing as actually being in that situation, right? There's always a granularity there. But we ask it as though it's kind of perfectly representative of what the actual situation is. And so it might, if we had a study, for example, that you might say, let's say we did a study and it turned out that the P4 was better at saying what the patient's preferences in the room when they're asked that question are than the surrogates are. I wouldn't necessarily be reassured by that, because in a future decision is always going to be different in important ways from the way that that's being proposed, in that it's not the same thing. It's not a one-to-one thing. And so I guess I could see a world in which, having that as one input would be relevant, but it might be helpful to surrogates. But I worry about, if it becomes kind of routinely used, what if we get into a situation where, we validate the P4 on these kinds of, situations, and then it disagrees with the surrogates, and I think we might be tempted under those circumstances to privilege the P4 over the human beings, and that's a future that I would really want to be wary of.
Thank you.
Really appreciate this talk, truly nodding along the whole time, especially as human beings get more and more lazy when it comes to gathering for these sorts of ethics committees and the burden that they put on that. And not only do you emphasize an existential point of view, a phenomenological one, applied one, and the inability of AI to track, going back to like Philip Mind literature, to track non-truth-bound states that the human imagination can, and how that kind of, factors into what you brought up about Husserl, retention, protension. That's a non-truth-bound endeavor, and AI, as you mentioned, methodically can only proceed in this truth-bound endeavor, which takes a lot away from the human experience. And I think that's definitely a strong point. And my only thing to say, like, what would you say to this counter, is that burden. As we get more and more burden of patients, people often talk about that when we're being economical and utilitarian about it. How do we continue to prioritize the human value of interaction, the sharing of fragility, over time and money?
Yeah, it's a good question. And so first to the you mentioned kind of non-truth bound, and maybe this also is another response to the previous question too, is that I think what I have learned from the phenomenological tradition is that truth in human affairs like ethics and politics is always contextual. And I guess this is part of my problem with AI, is that it seeks to escape context, to be above context, to be detached from context. And that in human affairs, it's always contextual. We can't detach ourselves from that. So it just generates truth in a different way from scientific method, inductive logic, things like that. So that, to the point about it's still truth, but it's contextual. I think, you're right that there would be incentives. This is another fear about the P4 that I would have, is that it's much more efficient than surrogate decision-making often is. If you participate in it, it often involves multiple family meetings just to kind of explain what's going on, and they struggle with it. Part of that stress means that they are not able always to come to a decision right away. And in a hospital system that prioritizes efficiency, time, and money, getting patients out of the hospital, getting a decision in as quickly as we can, there would be massive incentives to use the P4 as a way to sort of just end that process, to bring it to a close. So that's another reason, just on a practical level, that I think introducing it into a clinical milieu that, as you say, values time and money would even further undermine these goods of interaction and love that I think are important. Thanks.
All right, thank you so much for that talk. Our next presentation the title is Decline and Fall of Informed Consent, Long Live Shared Decision Making with Certified Patient Decision Aids. Theodis Mason Pope, JD, PhD, HEXC, is a foremost expert on medical law and clinical ethics. He focuses on patient rights and healthcare decision making, especially at the end of life. A fellow of the Hastings Center and previously both a Fulbright Canada Research Chair in Health Law, Policy and Ethics at the University of Ottawa, and a visiting scholar at the Brochet Foundation in Switzerland, Pope is now professor at Mitchell Hamlin School of Law in St. Paul, Minnesota. While professor, Pope serves in a range of consulting capacities. He has been particularly influential through extensive high-impact scholarship. Ranked among the top 20 most cited health law scholars in the United States and the top 50 in the world, Pope has over 300 law, medicine, and bioethics publications. Prior to joining academia, Professor Pope practiced at Arnold and Porter and clerked on the U.S. Court of Appeals for the Seventh Circuit. Pope earned his JD and PhD at Georgetown University. I look forward to your talk.
All right, so that's the title. That's me, Thaddeus Pope, Nothing to Disclose. So as you may know, this year we're celebrating a number of big anniversaries in bioethics, like the 60th anniversary of the Declaration of Helsinki and the 50th anniversary of the National Research Act. And when Ted Kennedy was holding the hearings on the National Research Act, a big focus back in the early 70s was that we cannot trust the investigator with medical research, right? We need to have external regulation, right? And of course, today we have this IRB process. What I want to talk about now is I want to move from the research context to the treatment context. And what I want to show is that we are moving to the same approach, external regulation, for treatment that we already have moved to for the research, and specifically with respect to informed consent, right? And when we first really formally recognized the doctrine of informed consent in 1972, what we did was we said, well, we put the physician in charge. We said, well, we'll let the physician take care of that. But what I think we all learned earlier this year was that when somebody is just not capable of doing the job, you have to give the job to somebody else. Here's my roadmap for the next 10 minutes in 3 parts. First, I want to just quickly describe a few design flaws of informed consent, then some failures of informed consent that flow from those flaws, and then describe this new paradigm to you. So design flaws. How many people got their fall 2024 COVID and flu vaccines? Oh, good. Okay, good for you. So I went to Walgreens, and this is just part of the thing that they handed me, which I guess is supposedly the informed consent. It's unreadable, and I actually expanded it just to fit on the slide, right? Unreadable, because Walgreens doesn't care if I can read it, right? The focus is disclosure. What they care about is, hey, we gave it to you, right? Whether you can read it, whether you can understand it, that's not our problem. We don't care about that. And it's not just Walgreens, it's across all healthcare, right? The focus is disclosure, not understanding. Just a couple analogies here, right? One is the focus is sending, right? The healthcare provider wants to make sure we sent the patient the information, the risks, benefits, and alternatives. Whether the patient received it, right, understood it, that's their problem. Second, if you've watched Law and Order, right, you know that when the police arrest somebody, they give them a Miranda warning. You have the right to remain silent. Anything you say can and will be held against you. And then at the end, the police say, do you understand each of these rights, right? Well, I can tell you the police don't care if you've understood the rights. They don't even care if you've heard it, right? Because the focus is disclosure. Have you Mirandized the suspect? Have you read them their rights? That's the focus. Disclosure, not understanding. And one last analogy, right? It would be like if there's a traffic safety issue, right? And we need to put up a sign to tell people there's a curve coming up or to slow down, right? And it would be as if the focus was put up the sign, right? Have you put up the sign? And nobody asks, well, can the drivers see the sign? Is it behind a bush or a tree? But the focus is all disclosure, not understanding. What's even worse is a few miles north of us here in Wisconsin, where things are even less patient-centered, right? And physicians disclose even less, right? Not what the reasonable patient would want or need or find significant, but what Wisconsin clinicians decide to disclose to Wisconsin patients. And it's not just Wisconsin, it's more than half the states. So just to recap here, it's a very low bar, and in some states, it's extra low. Okay, so failures that flow from this. Now, first of all, remember, there's only a duty to disclose, right? Not a duty to practically inform, just a duty to disclose risks, benefits, and alternatives. But there's two big failures, even from just that. One, it doesn't happen. And second, when it does happen, it happens badly. Just, we don't have time for a lot of examples, but a few. So Medscape, as you know, does big surveys with thousands of physicians. They ask this question: would you withhold risks deliberately from a patient to encourage consent? A quarter of respondents said, yes, I would, or I might. Another study, and this is a certain format of study where they record the patient-clinician interaction. They recorded 1,000 physician-patient interactions, and in those 1,000 interactions, they made 3,000 decisions. And the question was, when you go back and listen to the tapes, was how frequent was there a discussion of risks and benefits? Core, essential, basic risks and benefits. 9% of the time, right? Just 9% of the time. A fail rate, inadequate disclosure, 91% of the time. Another study, this is same type of study, you record the physician-patient interaction. This was specific to coronary interventions. How frequent was there a discussion of risks and benefits? Just 3% of the time, right? And we could do these studies all day long, but just one more. This was a study, same format, you record the interactions. This was for low-dose CT scans for lung cancer screening. How frequently was there a discussion of risks and benefits in those interactions? 0. 100% fail rate, never discussed risks and benefits. Bad, bad. That's a process measure because we're focusing on what the clinician is doing, right? Worse, we'll flip it, focus on an outcome measure. So now we're looking at the patient, right? We're looking at the outcomes. So now the question is, even if we have disclosed risks, benefits, and alternatives, did the patient understand them? No. Most patients are seriously misinformed. Again, just time for a few examples. This was an anesthesiology focused study. So again, the risks were disclosed. So they were disclosed. So for example, a risk of nerve injury was disclosed. Problem is, patients didn't understand what nerve injury means, right? They didn't understand that that could manifest as pain or weakness in an extremity. More troubling is this New England Journal of Medicine study. These patients were getting chemotherapy for incurable cancers. This is palliative only chemo. So there's no chance that this is going to cure them. But when you go and ask the patients, 30 to 40% thought it was very likely that the chemo was going to cure them. Another 20 to 30% thought it was somewhat likely when that was definitely not going to happen. And you see the same thing. This is 78% of patients with an ICD thought the ICD would forestall further heart deterioration. It definitely would not. And you have similar findings across clinical settings. Really disturbing. So to recap this, risk, benefits, and alternatives aren't disclosed, and when they aren't disclosed, the patient doesn't understand them. So here's what's happening. Mandated shared decision-making with patient decision aids. And the biggest player here, not the only one, is Medicare. So Medicare is increasingly requiring the use of a patient decision aid as a condition of participation with Medicare. In other words, what they're saying is, if you don't use a decision aid with this intervention, you're not going to get paid for doing the intervention. What we mean by a patient decision aid is an evidence-based educational tool. It might be a video, might be an app, might be an interactive website. It is presenting the patient her options clearly and almost always graphically. In meta-systematic reviews of decision aid research, this is recent Cochrane, 209 RCTs with more than 100,000 patients show really, really big impact of a decision aid. So Medicare started with screening for lung cancer with low-dose computed tomography. This is a benefit, a covered benefit under Medicare for long-time smokers. And the benefit is they get a chest CT scan. But before the CT scan, Medicare says the patient must receive a shared decision-making visit, and that must include one or more decision aids. Why did CMS do this? Because they had doubt. This is I'm paraphrasing their explanation. They had doubt that the patients were receiving accurate, unbiased, and balanced information from the clinician. CMS is telling these clinicians, your discussion with the patient isn't good enough. The patient must also get informed with the decision aid. And so they've been expanding this beyond. They moved to left atrial appendage closure therapy, to ICDs, to carotid artery stenting, to TAVR, and they're continuing, right? All of these, a formal shared decision-making interaction is required with an evidence-based decision tool. So just to recap, all they're doing is they're setting a baseline minimum of disclosure for these patients. So the old paradigm was, we'll trust the physician to discuss and provide informed consent to the patient. The new paradigm is it's the physician plus the decision aid, right? And I gave you some examples of what Medicare is doing and continuing to do, but it's not just CMS. It's FDA, and this is increasingly happening at the state level as well. So just to wrap it up, yes, physicians really, really dislike legislative and regulatory interference with the physician-patient relationship. They don't like prior authorization. But value concordant care is too important to leave solely in the hands of clinicians. Thanks.
Thank you. I think that's an important and necessary talk. I come from a lifetime of being a critical care surgeon, a chief medical officer, a member of a quality committee, and completely accept all of your premises. My question is, my worry is that once it's mandated that these decision aids need to be a part of informed consent, aren't you worried that this is going to abrogate the responsibility of the human relationship that has to take place between the surgeon or the proceduralist and the patient, that it will become inevitable that the physician says the decision aid is necessary even though on a human basis we know it's insufficient? I think it's an interesting echo of the previous discussion on AI. I mean, would you be comfortable with saying, well, we have the perfect decision aid in this AI platform that's personalized to the patient's questions, et cetera, et cetera. I mean, using the arguments from the previous speaker, I would say it's still insufficient, but I don't know how we bolster and maintain value in the human aspect of this.
Yeah, to dovetail this with the previous presenter, nobody is arguing, whether in the academic side or on the regulatory agency side, that any of these tools should supplant, S-U-P-P-L-A-N-T, should supplant the physician-patient discussion, right? They should supplement the physician-patient discussion, ideally before, right? So when the patient shows up in your office and sits down with you, you can say, oh, did you have a chance to look at these materials, right? So your discussion can start at a higher level and be a little bit more efficient and a little bit more focused on what the patient is actually really concerned about. So yeah, absolutely, nobody's arguing that we should do this instead of you talking to your patients. You should do this in addition to talking to your patients.
Thanks so much for the presentation. It's very interesting. Honestly, like the numbers are pretty embarrassing. My name's John. I'm a third-year med student at WashU. So I just wanted to first ask, like, what exactly is shared decision-making? Like, I see that word thrown out all the time. I read a note and it was like, yeah, shared decision-making was used with the patient when discussing a carotid endarterectomy. And I see the discussion, and it's like, you know, you should do this versus this, and then the patient says, I'll do that without a lot of reasoning behind it. So, like, so I guess, what really is shared decision-making? Like, how robust does it have to be? And I guess, secondly, like, what are sort of like required criteria for having shared decision-making rather than just saying, okay, like, because I think the tension is that it's not really, like, the set of choices that a patient can make for a management option are sort of constricted in the first place by what the physician, with their expertise, says, here are what I think, based on like literature, guidelines, and so on, are an acceptable range of choices that the patient may not have thought of or even known in the first place.
Yeah. So first of all, the fact you said you're a third-year medical student.
Yeah.
Right. So this is actually exactly, that's a great question, right? Because many people are like think, well, what is it? How is it different from informed consent? In fact, I don't think it is. I mean, the next thing they would say is, I don't think it is different than informed consent. It's just a new word. So the fact that you don't even know the answer, I guess, shows that there's a challenge here. The reason I think we started you see this word being used a lot more is because there is a goal to distinguish it from traditional informed consent, which I guess the way to say it simply would be is one way, right? Which is, I tell you your options and I tell you the risk benefits, and then you tell me what you want to do. In fact, while the idea with shared decision making, and in this I'm oversimplifying it for the sake of time, but is that then you would share back to me, so it's bilateral directional, what are you concerned about? What are your values, preferences, and goals? And then we would work together to figure out which treatment option best met your values, preferences, and goals. So I mean, it's more supportive, more facilitative than traditional informed consent. But the very fact you asked the question, there is a vagueness to it, which is why I didn't focus on shared decision making. I focused on what is often considered to be, not all of it, but an element of shared decision making, which is the use of decision aids, because the patient can't be a good conversant at the table unless they better understand their options. So when they sit down with the clinician to figure out which option best meets their goals, they need to actually understand what those options, that there are options, what the options are, and a little bit about each option.
Right, and I guess that was the sort of core of what I'm saying, is that the former informed consent is like necessary for, but not sufficient to say, I did share decision making with the patient. So I'm guessing like the thrust of your argument is that the decision.
There may not be, so just to be, if we had Venn diagrams, there may not be a difference between very, very good informed consent and shared decision making. But a lot of informed consent, as I tried to show, is garbage, right? And then that becomes that's very different than shared decision-making.
Right. Okay. So it's
In other words, you might just say shared decision-making is, I think, what Canterbury, what we, back when, or when Beecham wrote the Belmont report, I think shared decision-making is what I think people thought informed consent was going to be. It didn't turn out to be that way. And so that's why I think we wanted a new vocabulary to capture the fact that we want to distinguish it from what I think a word that got tainted a little bit.
Sure. Thank you.
Thank you for that wonderful talk. I use decision aids all the time in my practice, and I prefer practicing in that fashion. But my question to you is, you've demonstrated clearly that as a healthcare institution, we're failing at the patient in this very specific and important way. And is the decision-making tool that's being provided through, or being facilitated by a government control aspect, is that the best way to correct this problem? Like, who do you feel is responsible for this failure, or who might be the parties that are morally obligated to have a shift in practice? For example, the institution, should they be giving more time to the surgeon than like the 5 minutes in pre-op? Or, what is the circumstance of, are the people training the physicians in medical school? Should we be incorporating? There's lots of possibilities.
Yep.
What are the solutions?
Yeah, so absolutely. It's not a perfect solution, and it may not even be the best solution. And I think, and I'll concede all that, right? But I think it gets us higher than the baseline, right? So it's a net improvement, right? So you could pick a ton of things in healthcare, patient safety tools, right, that aren't going to eliminate infections, aren't going to eliminate lots of risks, but they reduce risks, right? The problem now is the quality of informed consent is producing enormous medical errors, right, in patient safety risks. This is not going to fix all of them. There may be other solutions that would fix them even better than this. But what I'm sharing is some of the most powerful healthcare regulatory agencies in our country. This is what they decided to start with. And so it may not be perfect, and it may not be as good as other things we could have done, but it's definitely going to improve things over the baseline.
Thank you. Medicine is science. Illness is an experience. It's like you could never tell someone what is hot until you have experienced it. Now, I was concerned about the last word you said, despite all good things, that doctors should not be the only one. So suppose you want to have this building made. Who else beside engineer you will talk about? Would you talk to the public? Would you talk to the committee? Once Albert Einstein was giving a talk, and a lady, older lady, maybe much younger than me, said, "Mr. Einstein, what is all this relativity all about?" He said, "Well, when I was in Germany, and they said he was a Jew, but when I came to US, I became famous. I was called Mr. Einstein." In a word, he talked to that person about relativity. So you give me a doctor who, with integrity and honesty, that's enough for me.
Thank you.
Hi, thank you for the great talk. I wanted to get your thoughts on the degree to which we're measuring the success of informed consent, or the process of informed consent. So throughout some of my medical training, some of the instances that I personally thought were really good was not necessarily if a patient sort of fully understood procedural details and risks and benefits, but more so whether they were able to really trust the physician who were caring for them, and were able to feel safe in putting sort of their life in the hands of someone they view to be like a respectable individual who genuinely care for them. And so I guess I'm wondering, with the use of this decision aid, if it's the most optimized way for us to sort of, I guess, firstly, what are some of the outcomes that we're looking at? And if it's patient understanding, does that really change the outcome in terms of whether patients feel safer, doing certain procedures with different physicians? And, is there perhaps a risk of, if we're overemphasizing the use of these decision aids, for physicians to perhaps perseverate a little bit too much on whether patients really fully understand details of a procedure that might not actually be ethically relevant?
Yeah, so I know we're running to this, but so first, absolutely, patients can delegate, right? So patients can say, look, I waive, they can waive, right? They can say, I trust you, doc, what do you think? And they can just waive their right to informed consent. People with capacity can have an advanced directive delegating an agent, even though they still have capacity, and delegate to the agent to make the healthcare decisions because they want to be relieved of that. So that's all fine. They can delegate or waive. But the impact is significant. So in the research, and there's, like I said, there's more than 200 RCTs. The decision aids, people make different decisions, right? So in population A versus population B that didn't get the decision aid, it has a big impact on the choices made, right? And I love there's a lot of research, but the Angela Valanda's research on DNR rates, right? You talk to your patient about their code status, patients with advanced cancer about their code status. You get like a 50% DNR rate. Then the other patients, you show them a 3-minute video showing them what exactly CPR is all about. You get an 85% DNR rate. And the only difference between the two sets of patients is that 3-minute video, right? Super big impact, right? And in general, the research are saying that's value concordant care, right? That those patients, we're making sure that patients are getting the treatment that they want and they're avoiding the treatment that they don't want. But yeah, the value of any of this is going to vary. Generally, it's going to be more valuable in treatment settings that are more preference sensitive, right? So it's not going to matter as much for your broken arm or things where it's not a very preference sensitive decision.
Thank you. I will be very brief since my comment was related to what you were just saying, which was full disclosure, I'm a surgeon, but I always wonder if the way to measure success in our shared decision-making or informed consent is by assessing the level of disclosure and understanding, or rather, how are we successfully measuring these goal concordant outcomes? Even in the study you just mentioned, do we know that a higher DNR rate was goal concordant care, or did we just overemphasize the risks of CPR and change people's decision-making? I don't think we have a good answer to that question, and I promise to be.
And the only thing I would say, just real quick, is it's the goal of decision aids, the ones that are certified and IPDAS compliant, is not just educational, right? It's also, they prompt you to reflect, right? So they'll prompt you to engage in a reflection about what you care about, and then start giving you information. So it's not just educational. It's a little bit of a guide for you to help think about this in a deliberative way.
I'll put a last plug for the work of Gretchen Schwarzy at the University of Wisconsin, who's a surgeon who is sort of trying to change how we teach ourselves to present the risks and benefits in a way that helps the patient process them as value and goal directed.
Yeah, no, Gretchen's.
Anyway,
great
He's
work.
not here to give the talk, but that's something you can look up.
Thank you.
Thank you for that. Our next talk is Managing an Inverted Knowledge Paradigm, Ethical Consideration in the Care of Patients and Families with Rare Diseases. Vanshika Narala is a third-year medical student at the Pritzker School of Medicine at the University of Chicago. She's interested in researching ethical dilemmas and healthcare disparities with a focus on improving access to quality and high-value care, especially in the pediatric population. Today, her presentation is regarding how the patient-physician relationship is altered in patients with a rare disease. We look forward to it.
Hi everyone, today I'm going to be talking about the ethical considerations in the care of patients and families with rare diseases. I have no relevant disclosures. So to start off our discussion, I want to set up a case. So a 2-year-old female with an ultra-rare disease is referred to a surgeon for a gastrotomy for feeding access. However, the patient's mom requests a feeding jejunostomy instead of a gastrostomy because the patient's mom is involved in some social media support groups for patients who are afflicted with the same disease and has made that decision based off of their experiences. The surgeon is hesitant due to the higher complication rates of a jejunostomy and therefore consults an expert on this ultra-rare disease. The expert states that there has not been any clinical or research data, so there's no evidence-based recommendation, and that, in fact, the social media support group may be the best and only source of available information. These type of clinical questions where patients differ with physicians are not uncommon in our practices, and there's often a normal algorithm that we follow for it. The first step usually is to look towards our literature, look towards what clinical data is present, what research has been there looking at long-term outcomes for these treatments. We can also consult our peers who are in similar specialties to learn about their experience and their opinions, or even contact a national expert in this disease case and see what they recommend based on disease progress as well as the long-term outcomes for different treatments. But what do we do when this paradigm fails? And unfortunately, this paradigm can often fail in the rare world. So what is the rare world? The rare world consists of patients and families who are afflicted with a rare disease, which is often defined as a disease with a prevalence of less than 1 in 2,000. With this definition, there's been over 7,000 diseases identified that affect over 30 million Americans. And out of all of these, there's only around 5% that have an FDA-approved treatment. So the vast majority of these diseases don't have any identifiable treatment plan or don't have the risks and benefits and long-term outcomes for a lot of different treatments recorded. There's also an increased role of non-physician-based and psychosocial support for patients who are in the rare world, which often takes form in social media support groups, and that's often how we get their communications. So in the rare world, while we might have unanswerable clinical questions present in a lot of different clinical settings, the rare world's unique because it leads to an inverted knowledge paradigm. In this case, the physician's knowledge is often limited by the lack of research data that's present, as well as a limited number of clinical experts and clinical experiences that are present in the medical field. And on the other hand, the patient knowledge is increased due to an increased personal understanding of the disease by the patient themselves, their anecdotal experiences either themselves or with other people that they've encountered through social media support groups or elsewhere that are afflicted with the same condition. So with this paradigm, the patient's knowledge is often increased compared to the physician. And this can lead to an impact on the physician-patient relationship. So normally, in the physician-patient relationship, the physician is the holder of knowledge. They're the one with the medical background, and they're the one that's in the medical field with easy access to experts or literature that can provide evidence-based solutions. And this often leads to the patient placing their trust in the physician's knowledge. And so while there is mutual participation between the physician and the patient, a lot of times when it comes to clinical decisions, the patient might defer to the physician. And the physician usually respects and understands different patient preferences and quality of life in order to make a clinical decision. In the rare disease world, this could be altered because the physician's knowledge is limited, and with the patient being the one that has access to various information about the disease, instead of the patient placing the trust in the physician, it requires the physician to place increased trust in the subjective information that's provided by the patient. So while there's still a mutual understanding and mutual participation, if the physician displays cautiousness about the information that the patient provides, the patient may feel dismissed and may feel as if their ideas and preferences are not being respected and understood. This could lead to a deterioration of the physician-patient relationship and lead to worse long-term outcomes for the patients. So in this case, these unanswerable questions are presented in the rare disease case, it's important to have an ethical framework to understand how we can work with our patients to get to a solution. So the ethical framework that we propose is to continue following the standard algorithm that we've discussed before, where we first look towards literature and clinical data to see what information we have about the disease and different treatments, and to still consult our peers and to contact national experts to get their opinions and get any other information we have. But especially in these cases, it's especially important to incorporate patient experiences, whether they're subjective or not, and take that into account when we're making our clinical decisions. It's also important to evaluate the information that the patient gives us based on the quality rather than the source. Like mentioned before, a lot of the experiences that these patients may be presenting may be coming from social media. And justifiably, a lot of physicians may be wary about information that comes from social media because of the rampant misinformation that we've seen spread through various healthcare topics such as vaccination. However, when we have so little objective information and when we're basing most of our decisions on subjective information, it's important to consider it based on the quality that we get it from and putting it in the context of our medical background rather than dismissing it simply because it's from social media. It's also important to consider that inaction is also a decision and does not necessarily equate to non-maleficence or doing no harm. When not providing treatment to a patient because we don't know the benefit of the treatment, we're still making an active choice, and that should still be considered a treatment option rather than just letting the patient not get a treatment. So overall, we should not let the patient suffer because of our lack of medical knowledge about the disease progression or because of the treatment outcomes, but we should talk with our patients and evaluate the information that we're given in the context of both the patient and our medical knowledge. With this said, the physician still retains the right to choose what treatments they're comfortable practicing and providing and should not be forced to go through an intervention that they feel does not have therapeutic benefit. So in conclusion, the rare disease world leads to an inverted knowledge paradigm due to a disparity in knowledge and access to anecdotal evidence between providers and patients. This leads to an increased value placed on subjective information. So while we should still consider clinical trial data and other research data first and foremost, when there's a lacking of this data, we should place a higher emphasis on personal experiences and experiences from social media in order to lead to a trusting relationship that the provider can establish by valuing patient preferences and quality of life and external factors in addition to medical indications. Thank you.
I think that you're touching on something where sort of, there's a lot of rhetoric around patients or patient families being the experts in their care, until they're not, right? Until they say something that sort of seems in maybe tension with what the evidence-based sort of medical literature says. Or so I think you're drawing out these situations where there's just a gap in sort of evidence-based literature and knowledge is really helpful. I'm wondering, you've posited it as this like either or, like we can, like if we have the literature and the evidence, great, and if we don't, then we can kind of hold more space for these alternative epistemic environments like social media. And I wonder if you and your colleagues are talking about alternative models for things like learning communities or other ways of thinking about scaffolding, peer support, opportunities, and more collaborative learning between patients and clinicians.
Yeah, I think you're right. I don't think it's an either or. I think there's definitely a big need for collaborative learning between physicians and patients, and especially in cases where we may not have all of the knowledge about a disease. I think it's important, if there is any literature that is present, to take that in consideration with what the patients provide. And I think it's also, even for non-rare disease cases where we may have a lot of research and a lot of literature that says that one might be the ideal treatment, I think it's still important to take into consideration patient beliefs and patient experiences and have those conversations together in order to come to a decision. Okay, thank you.
Okay, thank you for that talk as well. For our final talk, we have Olivia Orr, who is currently a Bachelor Research Coordinator at Ann and Robert H. Lurie Children's Hospital in Chicago. She's originally from Minneapolis, Minnesota, and received her undergraduate degree from Loyola Chicago, after which she attended University College London for a master's in health psychology, where she gained experience doing research within the national health system. When not working, she enjoys running and trying new restaurants in Chicago. Looking forward to your talk.
Hello, thank you all for sticking around. My name is Olivia Orr, and I'm a Behavioral Research Coordinator at Lurie Children's here in Chicago, and today I will be presenting on the topic, Conceptually Mapping the Ethical Components of a Clinical Encounter, Distinguishing Shared Decision-Making from Related Ethical Constructs. The only disclosure I have is that this work was funded by the Agency for Healthcare Research and Quality. And before I begin, I would like to acknowledge these individuals for their help and guidance throughout this entire project. Okay, so to start with some background, shared decision-making, or SDM, is an ethically important process for collaboration in medical decisions. It aims to support patients in decision-making by creating an exchange of information between the patient and the clinician, while, like we learned earlier, taking into account the patient values and goals. On the right, we can see a breakdown, or one of many breakdowns, of the elements of SDM. And for example, some of these elements include describing options and explaining the harms and benefits of treatments. SDM has shown to improve decision quality, patient knowledge, and patient satisfaction across many conditions. And for at least 3 conditions, the Centers for Medicare and Medicaid Services require SDM with decision aids for reimbursement. So it is clear that SDM is considered to be an important and useful part of the clinical decision-making process. Nevertheless, there are many patient care constructs that are important to medical decisions, and they may have overlapping elements with SDM. For example, informed consent also requires an exchange of information. These 2 quotes kind of further guided our research. So the first one is from a review by MacLean and Clayman, and it says that troubling is the low frequency with which authors writing about SDM recognized and cited previous work in the area. So the authors found that within SDM rarely recognized previous work in the area, and although this review may be outdated, more recently a review by Baumhoff-Roerdink concluded that many SDM models had difficulty distinguishing what was considered as context and what was an integral part of the SDM process. So these findings kind of steer us in the direction that the elements of SDM may have blurry edges within the context of the literature. So why does this matter? Well, in the past, SDM has been difficult to measure, and existing tools have limitations and wide variability. So for example, convergent validity between 2 of the most widely cited tools cannot be established, and furthermore, correlations of single items of the 2 scales revealed that the items that assess the same part of the decision-making process show no statistically significant correlation. So bringing in what was said in the past couple of slides, the difficulty in measuring SDM may relate in part to the difficulty in distinguishing SDM from other related concepts. So this kind of leads us into our 2 aims of this project, which was to conduct a normative analysis of SDM and compare its elements to similar patient care constructs, and then to identify the unique contributions of SDM to the existing literature. So how we went about this. So we approached these aims by comparing the elements of patient care constructs to those of SDM, looking out for places where there was complete overlap, partial overlap, conflicting guidance, or no overlap. And first, we identified the elements within SDM using 2 seminal articles, one a systematic review and another a Delphi panel of experts. And then we identified the related ethical constructs and their elements through conversations with experts and literature searches mainly focused on systematic or narrative reviews. These are the patient care constructs that we included. So I'll read them out in case you can't see them. Motivational interviewing, patient-centered care, informed consent, informed decision-making, patient activation, cultural humility, trauma-informed care, and shared decision-making. Obviously not an end-all be-all list of patient care constructs. I'm sure there's hundreds out there. So after comparing the elements, we found that most of the elements of shared decision-making had some level of overlap with other elements. Here are some examples of just the different levels. So just for one example, a complete overlap, what we consider to be a complete overlap. So SDM has an element that is to clarify decision exists and that there are options. And informed decision-making also has an element of discussion of the clinical issue, nature of the decision to be made, and the alternatives. So you can see those are very similar. Diving in a little bit further, we found that the most overlap occurred with patient-centered care, which makes sense because patient-centered care, the elements of it are a bit more broad than the other elements, so many things can and do fit within that. And then the least overlap occurred with informed consent, patient activation, cultural humility, and trauma-informed care. And then zooming out, looking at the bigger picture, we found that there were 3 themes or areas where elements overlapped. And to briefly go over these, the first was relationship building. So many constructs included elements related to laying an emotional foundation with the patient. SDM was a bit more vague about this, only having 1 or 2 elements, compared to other constructs, some of which specified how to do this for specific groups. So you can see at the example on the bottom, one of the elements within SDM is to foster partnership, which can mean a lot of different things, whereas in trauma-informed care, the elements related to relationship building were building connections, having respect, and understand your own history and reactions. And then the next overall theme was the clinician's role in the decision-making process. So several constructs included elements focused on the steps involved in decision-making. SDM more carefully defined the clinician's role in these steps, and these elements were more geared toward the clinician as the actor. And then these are just some of the elements within SDM that are geared towards the clinician. So the clinician should determine if SDM is appropriate and set an agenda for the consultation. And then finally, incorporating patient expertise. So almost all constructs included at least a few elements focused on the patient perspective, which is positive. And SDM was not necessarily unique in this regard. And then these 3 themes and looking at what elements overlapped with what constructs led to our 3 implications. So the first one is that there's no need to recreate the wheel. Some constructs are essentially describing the same thing. For example, the distinction between SDM and informed decision-making may be arbitrary, and for other constructs, there is a need to do more work to distinguish them from SDM and vice versa. And this really reiterates the point made by MacLean and Clayman in 2006 that authors rarely recognized and cited previous work in the area of SDM. And going forward, future research should be more careful about how it fits into the context of what is already out there. Our second implication is that SDM should neither focus on nor ignore relationship building. So the emotional foundation between a clinician and a patient is an important prerequisite to SDM, but not necessarily a part of it. Ignoring the emotional foundation would be problematic, however, because the patient might rate an encounter unfavorably if it is not present. And if we try to measure SDM in isolation, we might be getting it wrong. For example, a clinician can go through all the steps of SDM without laying this emotional foundation, but it's likely that the patient will not rate them very well, and the clinician will come off as almost robotic. And this really highlights the need for a way to measure the work done to lay that foundation in addition to SDM. And then our final implication, which addresses the second aim, clarifying the unique contributions of SDM, is that SDM should focus on the clinician's role in facilitating decision-making. Compared to other constructs, SDM focuses more on the role of the clinician and the work the clinician should do to set up a good decision-making process. For example, it had more elements explicitly addressing this than other constructs. With that, though, there are a few caveats to address. SDM includes decisions along a continuum of patient involvement and clinician directiveness. And one part of the clinician's role in SDM should be to correctly interpret where the patient lands along this continuum and facilitating discussion accordingly. Many patients have a different level in what they want to be involved in the clinical decision, and it's important that the clinician can get that level of involvement right. But it is still important to continue to measure SDM from the patient perspective. Sometimes the clinician might think they are doing things that the patient might not appreciate or take in a way other than what was intended. So where do we go from here, or future directions? So there's a need to develop more tools to measure all aspects of the clinical encounter, including setting that emotional foundation. New constructs should not be created without situating them in previous literature, and future research is needed to understand SDM in pediatric populations or populations where there may be a third actor involved in the clinical decision. That's all. Any questions?
Thank you so much for presenting this. I think it's probably more of a comment, but in my experience as a palliative care physician, I think that, there's the foundation that you're talking about is so important from the moment someone steps through the doors of the hospital or comes into the hospital. And I think that sort of this idea that these are long conversations that it's almost like this daunting task of everything that has to go into eliciting values and preferences and having the shared decision-making role or conversation and the physician's role in it. These are small moments on morning rounds. These are small moments of I hope this, but I worry about this from the moment someone comes in. And I think that could help with the foundation as you go into that quote unquote goals of care 10 days later, that there's some foundation built that we have a lot of hopes and here's what they were. We talked about worries. Can we now explore those worries? And my second statement is I think that my worry in the procedure of serious illness conversation is there is not a lot of adequate role modeling of it for learners. And my worry is that a lot of patients are actually having these really challenging discussions with some of our newest physicians or clinicians on the team. And so I do think it is a duty on the part of the attending physician or primary provider to have the responsibility for the communication that is presented to the patient ultimately is the responsibility of that provider. And I think to go through a training where interns are the first people to have these conversations, not necessarily have coming from a training in medical school where they had a lot of role playing or a lot of role modeling of this is quite troubling, at least I've seen in my experience. So I really appreciate you looking into this.
Thank you.
My comment was along the same lines. I really appreciate your presentation as well as the previous comments on this. I have been giving a lot of thought to this, especially working in a setting with people with disabilities and sort of prerequisites to shared decision making when there's not maybe same lived experience and a lot of bias and stigma. And so I think that there's maybe opportunity and room for more of those foundation building prerequisites and the idea of kind of building trustworthiness, since we know that it sometimes doesn't exist in institutions. Maybe our starting points can be different in that way. And I just wonder if there's more, if you're aware of or if others are aware of more work in that vein. So I'd love to hear more about that too. Thanks.
Just to follow up on the previous comments, has your approach to this problem and your 30,000-foot view of the resources being devoted to this come across any supportable examples of improving communication in this realm, such as the use of simulation of critical conversations, narrative medicine, improvisation, et cetera? Because as previous speaker noted, oftentimes, unfortunately, we do defer to the least experienced individuals. There are a dearth of role models, although there are excellent role models also. Tell the medical students you can learn from the bad examples as well as the good examples. But I'm interested in any work you might be aware of effective simulations of these discussions.
I don't know of any off the top of my head, but I'll keep an eye out and follow up if I come across anything.
I just wanted to also ask about sort of what you see the role might be for this work in developing training for some of those models in the future, how some of this work of disaggregating what counts as shared decision-making versus laying an emotional foundation or other things might help with that.
Yeah, I think that's a good question. As far as for training for clinicians, I'm not a clinician, so I don't know what training they go through already, but I think it's just important to, it can be a very pragmatic, process-oriented approach to care, and the medical field today, it's a lot of in and out, quick, trying to be as quick as possible, but really making sure that in the end, these shared decision-making becomes better and more viable when emotional foundation is set beforehand. And I think making sure to emphasize that point throughout, and that you can do these things, incorporating this emotional foundation and building this relationship with the patients in a pragmatic approach, but in the grand scheme of things, also that makes it a better approach for the patient and the outcomes on the other side, if that answers the question. Okay.
Can add the training that's available for folks. So Palette Talk, We Talk, Vital Talk, all of those are ways in which you can have simulation-based role modeling, role-playing practice in these skills with patient-tested language, which is very helpful.
Thank you.
Thank you to all the presenters. Great papers. We're going to take a short break now. As you see on the program, there are going to be, just outside the back door here, there are some posters up, and there will be a poster walk with the posters presenting their work. And if you would like to join us for that, that will be starting in about 10 minutes, I think, according to the schedule. Thank you.